Good morning. So I'm Dr. Roopesh Singhal. I'll be speaking on refractory heart failure. We know that heart failure is a major problem and major concern. And with the widespread epidemic of cardiovascular disorders and increased survival of post myocardial infarction patients, we now are going to see a much more with an aging patient, a lot of subset of these patients. We already know it has around 21 million adults worldwide living with heart failure. It's a huge economic burden, costing about, even in way back in 2012, it cost 108 billion, and this number is going to just increase. The mortality is 50%, as we know from the Tristry Heart Failure Registry. Rehospitalization it's the number one cause of rehospitalizations in patients aged over 65 and accounts for has patients with a lot of comorbidities. So we know that heart failure is a clinical syndrome that can result from any structural or functional cardiac disorders that impairs the ability of the ventricle to fill or eject blood. We know various etiologies. It can be because of valvular heart disease, pericardial disease, systemic conditions such as anemia, sepsis, thyrotoxicosis, Paget's disease, arteriovenous fistula. It is important to consider this because these are actually reversible causes and can be treated. Volume overload from secondary to renal failure or increased IV fluids, like in iatrogenic. It can be because of myocardial disease such as coronary artery disease, hypertension, which is the most common cause for heart failure worldwide. So hypertension and coronary artery disease count for the majority of patients of heart failure worldwide and even in India. So we have been involved in the National Heart Failure Registry. I am the principal investigator for one of the 6 nodal sites, and even in Indian subset, we found a very high percentage was because of ischemic heart disease and a very high level of comorbidities. Then it can be because of endocardial disease, arrhythmias, conduction disorders, and congenital heart disease. So what we must actually understand is heart failure is a gradually silently progressing disease, and once the patient is symptomatic, it's actually too late in the spectrum of heart failure. So heart failure, according to ACEI, they have classified it as stage A, B, C, and D, symptomatic from stage C, which is further can be classified as per the NYJ class. Class 1 is asymptomatic, class 2 is symptomatic with moderate exertion, class 3 is symptomatic with minimal exertion, and class 4 is symptomatic with rest. So it's a stage process. You need to assess, even the diagnosis, you need to assess the comorbidities, biomarkers, echo. We need to do invasive tests to rule out coronary artery disease, cardiac MRIs, and viability studies and thalamic scans for finding where the pathology is. And this must all be done in a stepwise manner. A particular, like if you, so if you have a symptomatic heart failure patient, you'll do the basic laboratory investigations, including various electrolytes, a 12-lead ECG, chest X-ray, and echo. These are the basic investigations. If you suspect ischemia, stress imaging, or cardiac cath should also be considered. And a specific, so BNP is now a well-established zero marker for heart failure. It can be used for diagnosis, staging, risk stratification, risk assessment for rehospitalization, and to actually differentiate from other causes of dyspnea. So it is a very useful investigation, and I'm now, with time, most of us are already incorporating use of BNP in our practice. So treatment objectives for treatment include reduce mortality, improve quality of life, eliminate edema, fluid retention, and reduce the fatigue, reduce the need for rehospitalization. So what can we do about it? This was the ACEI guidelines that we are all familiar with. Let's concern ourselves with refractory, that is stage C and stage D heart failure despite guideline therapy. So like what can we do? So if you see, this is a very nice stepwise treatment of heart failure. Start with risk factor modification, treatment of other comorbidities, ACE inhibitors, beta blockers, sodium restriction, CRTs, revascularization, and aldosterone antagonists, ionotropes. Finally, ventricle assist devices and heart transplantation. So which medications? We all are aware of this, but we should also say diuretics are the most commonly used drugs, but they have a very questionable effect on mortality. So we must keep in mind that we need to reduce the symptoms, but also decrease hospitalization, decrease mortality, and we need to go by guideline-directed therapy. So ACE inhibitors reduce the mortality by 70, relative risk reduction for mortality is 17% with ACE inhibitors, 34% with beta blockers, 30% with aldosterone antagonist, and 43% with hydrolyzing, giving a number needed to treat as shown in this table. So one must also understand that these therapies are, cumulative and mutually synergistic. So you just adding therapies in different class of drugs is not just adding medication; it's also adding life. You're actually giving a life to the patient. And management, and especially in refractory heart failure, we need to educate, implement physical activity and cardiac rehabilitation, sodium restriction, treatment of comorbidities, vaccinations against influenza and pneumococcal, decrease or alcohol, smoking, and other abuse. And we need to also educate about avoiding certain classes of drugs such as NSAIDs and calcium channel blockers. And we need to sort of modulate our treatment of arrhythmias, especially in diabetes. Like we need to avoid thiazolidines, and which are now very famous. Again, similarly for stage D hypertension. So what are the problems and what are the common loopholes? We must, so adherence to guidelines, like if we see diuretics, which have a questionable effect on mortality, are the most commonly prescribed use of class of agent, whereas ACE inhibitors is used in only 61% patients and only up to 50 to 60% of target dose. Beta blockers is even less commonly used, and target dose, the usual clinical dose is much lower than the clinical dose and the target oriented dose. So with guideline directed therapy, you can reduce heart failure hospitalization. So we must know that carvedilol is up to 40 milligrams, but up to 200 milligrams, ramipril 10 milligrams, and valsartan 160 milligrams BD, aldactone 25 milligrams, and nitrates. And now with Digitalis can be used in patients with heart failure with atrial fibrillation and can be used for rate control. The Ernie's, we all know this trial. And again, it is important that we must take these drugs in optimal doses, beginning with 50 BD and try to achieve 200 milligram BD to provide maximum benefit. Similar with ivabradine, uh, only when there is no proper rate control with adequate dose of beta blockers. So hyperkalemia needs to be treated. There are now studies in the way which have potassium, binding agents in heart failure to improve the adherence to therapy. We must address the comorbidities, COPD, hypertension, angina, renal dysfunction. All this must be properly treated. Diabetes mellitus, we now have DAPA-HF, and we know that dapagliflozin can actually help and aid in the treatment of uh, diabetes. So that must be done. And we can actually use that. Then treatment of anemia, gout, hyperlipidemia, depression, psychiatric illness, and other psychiatric illness must be addressed too. So coronary artery disease, we all look into it, but we also need to account for diabetes, sleep apnea. So sleep apnea is one commonly misdiagnosed, sleep apnea and COPD. So you must check for it, especially in obese metabolic syndrome patients. CPAP can actually reduce the heart failure hospitalizations. And arrhythmia, again, atrial fibrillation is a very common problem and can actually precipitate heart failure. So it is very important. We should try and achieve adequate rate control, if feasible, also rhythm control. And it is very tricky because all these patients are debilitate, and all these drugs affect the other systems as well. So you can use beta blockers and digoxin for rate control. Amiodarone can be used for rhythm control in a selected patient. Anticoagulation must obviously be adhered to prevent thromboembolism. So we can start with beta blockers, add digoxin, can substitute amiodarone for digoxin. If similarly in HFpEF, we can start with CCBs, add digoxin or beta blockers, and then maintain therapy. If not controlled, we can take electrophysiologist opinion, and for AV node ablation. ICDs again can be used for sudden cardiac death prevention and must definitely be prescribed to. We all know this indications for ICD, similarly for CRT. So CRT in wide QRS with LVB morphology over and above guideline like therapy in refractory heart failure can definitely help in treating these patients. So that is more or less it. And I'll welcome any questions. You can mail any questions to me at roopeshsinghal@gmail.com. Thank you.